So again, we will be discussing today tumor immunology. Okay, so for this particular lecture, we will be dividing our lessons into the following: tumor biology, tumor antigen, uh, relevant tumor markers, laboratory tests for tumors, the immune defense against tumors, immunoediting, and tumor escape, plus the immunotherapy. Okay, so let us define first what do we mean by a tumor. A tumor is classified as a neoplasm. And when you say a neoplasm, it is actually an abnormal cell mass which can either be classified as benign or malignant. So let's jump to this particular slide. No, so when you say neoplasm, it results from new growth of cells. So we call that neoplasia. That would not ordinarily induce multiplication of cells, thus the growth of tissues. So a while ago, I told you that there are two types of neoplasm. So neoplasm could be benign or malignant. So when you say benign or malignant, um, benign neoplasm is characterized by slow growth. Okay, so that's our characteristic of benign. So slow growth, restricted anatomic location, and does not cause death. Doesn't usually cause death. Okay, and when you say malignant neoplasm, slow or rapid growth, there is anaplasia, invasion of the antibody, and metastasis. So when you say metastasis, it means that um, the the malignant cells have actually spread in different location already. And then this particular metastasis can result in death. So it is also termed as cancer. So that's the reason why in tumor immunology, in tumor immunology, we have it is actually associated with cancer, especially if we're talking about the malignant tumors. So cancer is primarily defined as malignant tumor that can spread. So actually, this particular cancer is caused by mutations in proto-oncogenes. Okay, what is a proto-oncogenes? So when you say proto-oncogenes, we are usually referring to normal, we are actually referring to normal genes that are necessary for cell proliferation, okay, and development. As you can see in this particular graph that you are illustration here, so there is usually cells that would proliferate and develop. However, mutations in proto-oncogenes can convert them into oncogene-like, okay, resulting in continuous division. So, so if there is a mutation in the oncogene, proto-oncogene, there it becomes oncogene-like. And this oncogene-like will still continue and proliferate until such time that this oncogene-like so results into cancerous cells, and these particular cancerous cells can therefore spread in other organs of the body. That's what you call um, metastasis. Okay. Then there's also what you call tumor suppressor genes. Okay, so when you say tumor suppressor genes, these are normal genes that regulate cell cycle and control cell division. Okay, tumor suppressor genes, as the term imply, this will suppress tumors. And these are important to regulate the cell cycle and to control cell division. So whenever there is a mutation in the tumor suppressor genes, there could be cancer. Okay? And cancer will result into uncontrolled cell division and other characteristics. So therefore, we do not want to have mutations in proto-oncogenes and tumor suppressor genes. Again, just a review, when you say proto-oncogenes, these are necessary for normal cell proliferation and development. When we say tumor suppressor genes, this will regulate normal cell cycle and normal cell division. It will control normal cell division. So whenever there are suppressions in these genes, this can result to cancer. Okay? So as you can see, this is the normal cell division. However, if certain mutations happen, then these particular mutations can result into a cancer cells that can have uncontrolled cell division. Okay? And what's the characteristic of a cancer cell? So, according by Hanahan and Weinberg, according to Hanahan and Weinberg in 2000 and 2011, they have characterized cancer cells to have sustained proliferation, resist death. So somehow they have what you call immortalization. They can induce angiogenesis, meaning to say more blood vessels are formed. More blood vessels are not really good for us because this can actually induce metastasis. So resist that results into immortality. Invasion and metastasis means that it can actually spread to other organs. It avoids suppressors of cell growth, altered metabolism, evasion of immune defenses, genomic instability, and accelerated growth and presence of inflammation. Okay, so again, whenever there is um, an abnormality, that this can result, and then the cells becomes unprepared, there would be what? Resist apoptosis. The cell will not die. There would be uncontrolled cell division, induced angiogenesis, and then until such time that these particular cancer cells will now invade other organs. Okay. So, however, our immune system will not go undefeated right away because there is still an evidence that we are fighting the cancer cells. And these are the evidence for immune response. Sometimes there could be spontaneous regression for some patients. Okay? Some patients would have long-term indolence wherein the cancer cells are could be in remission. And then of course, mononuclear response, meaning to say um, the cancer cells will be infiltrated by monocytes, meaning to say our monocytes are still fighting them. And then there could also be a evidence of post-surgical detection of malignant cells, autologous tumors, and positive, immediate, and delayed hypersensitivity skin tests. These are all evidences that our immune system has actually mounted an immune response against these cancer cells. Okay, so as a result of this immune response, we, our immune system, would actually react to antigens that are unique to a certain type of tumor. So we call it the tumor specific antigens. Okay, so actually there are several examples of tumor-specific antigens. Okay, so these tumor-specific antigens can be classified as oncofetal genes because they were developed at the time when we're still at the fetal stage. And the other one is the viral component proteins or enzymes. These viral component proteins or enzymes are actually due to oncoviruses. When you say oncoviruses, these are viruses that can induce cancer or tumor. And an example of that is Epstein-Barr virus. So Epstein-Barr virus is an example of oncoviruses. There are many tumor-specific antigens. Okay, so let's discuss, for example, um, oncofetal antigens. The reason why we call it oncofetal antigen is because they are present during the normal fetal development. So normally, as we grow older, it is being lost during differentiation of tissues and reappear during malignancy. So during fetal development, oncofetal antigen is present. Okay, as we grow as an adult, normally, normal individual, it disappear. But if an individual, a normal adult would have cancer, the oncofetal antigen will reappear. And one good example of oncofetal antigen is the AFP, okay, or the alpha fetoprotein. So the AFP or the alpha fetoprotein is synthesized and secreted in the liver, and they are found in cord blood. So they are detected in hepatomas or cancer of the liver. And aside from cancer of the liver, it is also being seen in malignant cases, non-malignant cases such as cirrhosis and hepatitis. So alpha fetoprotein is only one of the example of TSA or the tumor-specific antigen. And we are using alpha fetoprotein as a prognostic index or marker of a successful chemotherapeutic success. Meaning to say, if the level of AFP after chemotherapy becomes very low, meaning to say that particular patient is on the road for a success. It means that that patient has a very high prognostic index after a successful chemotherapy. Okay, so that's only one of the examples of many type of TSA. Okay, so in summary, TSA is unique to the tumor. Okay, and it is coded by mutated proto-oncogenes or tumor suppressor genes. Okay, so there are many examples of TSA. So a while ago, I did mention about alpha fetoprotein as an example of oncofetal antigen, but there's another one. This is the BCR-ABL gene. Okay, so the BCR-ABL gene is found in patients with CML. What is CML? CML stands for chronic myelogenous leukemia. Okay, so BCR-ABL is actually a rearrangement, okay, rearrangement of the BCR and ABL gene, particularly in the Philadelphia chromosomes. Okay, so Philadelphia chromosomes. So actually, it's a translocation between a chromosomes number 22 and chromosomes number 9. So the hybrid of this particular translocation will produce a fusion protein that results in uncontrolled cell proliferation. Okay, so that's why it's called BCR-ABL. So here you have the ABL gene, in chromosome number 9, and then the BCR gene in chromosome number 22. So because of the chromosome break, there is a translocation, and the newly formed fusion is now known as the BCR-ABL gene. Okay? So the change in chromosome number 22 or the newly formed fusion is otherwise known as BCR-ABL, and this one is implicated. This one is implicated in chronic myelogenous leukemia. So that's one example of PSA. So another example of PSA are those that are caused by oncoviruses. Okay? So when you say oncoviruses, these oncoviruses are cancer-causing viruses such as the Epstein-Barr virus, the human papilloma virus, and the human T lymphotrophic virus 1, HTLV. So these are all examples of oncoviruses. Okay. So the tumor-specific antigens are expressed. So aside from the previously mentioned antigens, the tumor-associated antigens are expressed in tumor cells and normal cells, and it is being shared with the tumor-specific antigens. So on many tumors, but not in most normal tissues. Okay, so MAGE proteins are example of tumor-specific antigens that are being shared, okay, on melanoma tumors. So meaning to say, normal tissues may have MAGE proteins, but it is more common in melanoma tumors as compared to normal tissues. Okay. So aside from that, we also have the differentiation antigens. So differentiation antigens are actually found on immature cells of a particular lineage. Kaya nga, yung immature cells, usually during the fetal development or during the oncofetal development. A while ago, I have discussed about alpha fetal proteins, but there are many examples of antigens that are found in immature cells. So example, we have the CD10, also known as the CALA. What is CALA? CALA stands for common, acute, lymphoblastic leukemia antigen. So obviously, CALA is a marker. So we are using it as a marker for the pre-B cells during cases of acute lymphocytic leukemia. So if we say that the person has CALA, so meaning to say that person has a pre-B cells acute lymphocytic leukemia, CALA or CD10. So a while ago, we talked about the alpha fetoprotein, and we associate the alpha fetoprotein in cases of liver hepatoma or liver cancer. And then we also have the PSA. PSA is the prostate specific antigen. And usually it's a marker that we are using for prostatic carcinoma. Okay? And then we also have the CEA. CEA stands for carcinoembryonic antigen. CEA stands for carcinoembryonic antigen. Carcinoembryonic antigen is detected in the gut. So this one is detected in the gut, liver, and pancreas of normal fetus during second trimester of pregnancy. Adult would have low levels in serum. However, 70% of cases of colon cancer would be positive for CEA. Okay. Now, if a person is a smoker, so there's also a possibility that CEA will occur as well. And it is a prognostic marker. So if the chemotherapy, let's say, has been very successful, then the level of CEA will be very low. Okay, so um, what can we say about CEA, AFP plus PSA? Okay, these are all examples of oncofetal antigens. Okay, so when you say oncofetal antigens are being expressed on cells of the fetus, but not on adults unless you have a cancer. Okay, so usually during fetal development, oncofetal antigens are present. Okay, unless you have a cancer. Now, aside from that, we also have the overexpressed antigens. These are found in higher levels on malignant cells. Okay, example, HER2. HER2 stands for human epidermal growth factor receptor 2. That's why it's called HER2. Okay, amplified in certain type of breast cancer. So, for example, if a woman has high level of HER2, meaning to say that woman probably has a breast cancer. So these are overexpressed. So if CA125, CA1919 are present, then it is associated with a certain type of cancer, which we will be enumerating at the latter part of the presentation. Okay? And then when we say clinically relevant tumors, okay, clinically relevant tumors are biological substances found in increased amount of blood, body fluids, or tissues of patients with a specific type of cancer. So concentration in serum depends on amount of tumor proliferation and tumor size. Elevated level indicates significant tumor mass. Okay, so concentration of serum tumor marker also depends on proteolytic activities. Concentration of serum tumor markers also depends on proteolytic activities of tumor and release of the marker from dying tumor cells. So that's the reason why if a tumor marker is increased, we cannot really conclude. Okay, so because sometimes we have to consider whether the tumor markers were released, but the tumor or the cancer cells are already dying. But generally speaking, when the tumor markers are increased, it's a bad thing because it means that there is a significant tumor mass or the mass is actually increasing. Okay, so that's the reason why clinicians are correlating tumor markers with the result of the biopsy and with the clinical conditions and other laboratory tests of the patients. So it's not really, they will not solely rely their management on tumor markers, but tumor markers are helpful for the clinicians. Okay. Tumor markers can be used also for population screening. So, for example, you want to determine which among asymptomatic male will have PSA level, because if a certain asymptomatic male would have high level of PSA, it's very good because in terms of management, because we'll be able to detect cancer at an early stage. However, However, you have to be careful because there's also a possibility of getting false positive and false negative results. And if it's false positive, it will give undue stress to that person. Okay? And it can also be used for diagnosis because it can identify cancer in a particular patient. Tumor markers are also being used for patient prognosis because it can predict clinical outcome and aid in the selection of therapy. So, for example, if HER2 is increased in amount, one can consider breast cancer, and the clinicians or the oncologists will consider what therapy would be appropriate for that particular patient. So, yeah. And of course, tumor markers can also be utilized for the monitoring of response to therapy. So let's say, for example, this particular graph will monitor a certain type of cancer, no? So they are using CA125. So let's say, for example, during surgery, there is a decline of marker consistent with biological half-life. So, naalis mo na yung tumor and the tumor marker becomes very low, okay? And there is not anymore evidence of the disease. But there is a relapse. When you say relapse, um, it means that the cancer cells reappear again. So chemotherapy has been given to the patient. First cycle, let's say first cycle. And then here, the clinician would say that therapy is unsuccessful because the level of CA125 keeps on increasing. And then the second cycle of chemotherapy is given. And then the therapy seems to be successful because the amount of CA125 is decreasing until such time that there is a remission, meaning to say there is no anymore evidence of the disease. So again, this is how this is one of the important use of tumor markers. We are using this, okay, to determine whether the therapy is successful, whether there's a chance of recovery or a chance of successful therapy or not. Okay, so that's the reason why these are some of the most common examples of tumor marker and their uses. So again, um, so when you say S, it is used for screening purposes. When you say D, it is used for diagnosis. And we say P, to determine the prognostic index or the chances of recovery. And M, for monitoring. Monitoring, like this one is example of tumor marker being used to monitor the progression of the disease. So AFP, alpha fetoprotein, for liver and testicular cancer can be utilized for all SDPM. The same thing with CA125, that is for SDPM, screening, diagnosis, prognosis, and monitoring. And PSA for the prostate cancer is also for SDPM. CA199, the tumor marker for pancreatic cancer, is only used for DPM, meaning to say it is not being used for screening. Whereas the carcinoembryonic antigen for colorectal and breast cancer is only used for prognostic index and monitoring, but not for screening, not for diagnosis. Whereas the HCG, which will determine testicular and trophoblastic cancer, so this one is in the placenta, is only used for DPM, which means to say not for screening. Okay, so these are the common utilization of tumor markers. So I have here some of the most commonly used tumor markers. So we have AFP, alpha HCG is for pituitary tumors, beta 2M is for B-cell neoplasia, CA153 is for breast carcinoma, CA199 is for CA99 is for um, pancreatic and gastric carcinoma. CA7224 is for gastric carcinoma. CA125 is for ovarian carcinoma. Beta HCG is for choriocarcinoma. Benz-Jones protein is for multiple myeloma. Bombacin is for oat cell cancer. So, madami pa yan. CA549 is breast cancer. CAM26, breast cancer. Calcitonin, medullary carcinoma. CERB2 oncoprotein for breast carcinoma. Chromogranin A is for pheochromocytoma. CIFRA211 is for squamous cell carcinoma. Desmeterol is for brain tumor. DHEA is for adrenal and pituitary cancer. DNA, cervical carcinoma. EPO is for renal carcinoma. And then ferritin for acute myelocytic leukemia. Galactosyl transferase for ovarian cancer. And the galactosyl transferase isoenzyme 2 is for pancreatic cancer. Gastrin for gastrinoma. Staminase is for medullary thyroid cancer. HCG intact molecule is for cariocarcinoma. Hyaluronic acid is for mesothelioma. IgA is for multiple myeloma. IGF-1 is for pituitary cancer. Interleukin-2 receptor is for leukemia. Dami, no guys? IGS is for multiple myeloma. Inhibin is for granuloma cell tumor. Insulin-like growth factor is for non-islet cell tumor. Catacalcin is for medullary thyroid cell cancer. 17-ketosteroid is for adrenal pituitary cancer. Lasap-P is for various carcinoma. Melanoma-associated antigen is for melanoma, obviously. Metanephrine is for pheochromocytoma. Neuron-specific enolase is for small lung carcinoma. Pancreatic polypeptide is for endocrine tumor. More to come. P21 protein is for breast cancer. Plasma catecholamines is for pheochromocytoma. PNP is for leukemia. POA is for pancreatic cancer. PSA is for prostate cancer. PS2 protein is for breast cancer. SCC is for leukemia. TDT, acute lymphocytic leukemia. Thyroglobulin is for thyroid cancer. TTA is said to be non-specific. The TAD72 is for gastric carcinoma. Urokinase inhibitor is for bladder tumors. And VIP is for lipoma. Okay, so I hope you are not overwhelmed by some of the most commonly used tumor markers. In fact, I do believe that I haven't enumerated all. I just included some of the most commonly used, and my reference for those lists were from Laboratory Diagnosis by John Bernard Henry. Okay, now, laboratory tests for tumors. So there are several examples of laboratory tests. Immunohistochemistry can be used. Let's say PBT is an example of immunohistochemistry. Here, we use labeled antibodies to detect tumor antigens in tissue biopsy. So immunoassays can be done, and it measures level of circulating tumor markers. Molecular methods is another way. So I think we have already discussed this one during molecular diagnosis. We can detect genetic mutations associated with cancer, such as using the polymerase chain reaction or the FISH or fluorescent in situ hybridization. We discussed also about microarray and DNA sequencing in previous lectures. Proteomics is that it detects proteins profile of a tumor populations, and this can be done through antibody arrays. Okay, so these are some of the tests that's being done in the laboratory. But in the lab, I think the most common way of detecting tumor markers would be through immunoassays. Okay, so the immunoassays for serum tumor markers is sensitive, and it is an automated method. And the reagents may vary, so it's one of the factors that we have to consider. Cross-reactivity, we do not want this to happen because this one can result false positive. And then antigen excess can produce false decrease. It is the high dose hook effect. if you still remember our discussion of post-zone phenomenon, which can result to false negative. And then there is also a possibility of interference by heterophile antibodies, anti-animal or autoantibodies. So what do you mean by heterophile antibodies? In patient serum, it can result in false decrease or false increase. Okay, so that's the heterophile antibodies. So in this particular figure, you would notice that the figure will show false increase resulting from the ability of the heterophile antibodies. Sorry. The figure will show false increase. So there is already a false increase resulting from the ability of heterophile antibody to link the capture antibodies to the label detection of antibodies. So heterophile antibodies will cause the signal to increase, but heterophile antibodies are not tumor markers. Not tumor markers. Okay, so it will cause either false decrease or false increase. The hook effect is actually different. Okay, so the hook effect is different because in hook effect it is also known as the high dose effect. So high dose, there is an area of antigen excess, a same signal but different concentration. So it's not any more accurate. So a while ago, I told you that our immune system will not give up the fight. Okay, so our immune system will still mount a defense against the tumor cells. And this is evidenced through immunosurveillance. So this particular theory was first proposed by McFarlane Burney and Lewis Thomas in 1950s, and it illustrates the importance of immune system in defending the body against tumor. So immunosurveillance, so it is as if that our immune system will have highway patrol, and they will actually survey for it. They will have a very strict surveillance of our body for cancer cells, and once they found cancer cell, they will destroy them before they become clinically evident. So our innate defense or the natural defense will involve natural killer cells and macrophages. And our adaptive immune response would involve cytotoxic T cells, dendritic cells as antigen presenting cells, cytokines, and antibodies. So meaning to say, our bodies will do its best, our immune system will do its best to fight cancer cells, so that cancer cells will undergo apoptosis or programmed cell death. So various mechanisms are actually summarized in this particular slide. So as you can see, um, uh, we can the membrane attack complex of the complement can destroy the cancer cells. Lytic enzymes, tumor necrosis factor, as produced by the antigen presenting cells will produce cancer cells, and then the T helper cells will ask B cells to produce cytokines, and then plasma cells will produce antibodies, and antibodies will destroy the cancer cells, and antibodies will be combined with complement so that there will be a membrane attack complex against the cancer cells. On the other hand, the natural killer cells will allow ADCC to happen, and then cytotoxic T cells can produce granzymes and perforins to destroy cancer cells. So it means that we are not uh, defenseless against cancer cells. Just so happen that sometimes our immune system becomes overwhelmed. However, even as you can see here, no, in the graph, our cells are doing its best. However, cancer cells can still escape our immune system. So tumor cells may still escape the immune defense and grow to form a clinically significant mass. Ito na yung tumor kapag meron ng mass. So the relationship between the immune system and cancer cell is complex and has been explained in a process, and there are actually three processes. The first one is called the elimination phase. Here, elimination phase is like, it is the same as immunosurveillance. So here, we have a robust, innate, and adaptive immune response, and this will kill most of the tumor cells. So tumor cells identified by antigen and MHC1 induced to apoptosis and FAS ligand. So we're still fighting. And then the second phase is called equilibrium. So, but why do we call it equilibrium? Because some tumor cells escape the immunosurveillance, nakalusot pa rin. Okay, so some tumor cells will escape the immunosurveillance mechanism and may remain dormant or evolve slowly over time. So immune system controls limited number of altered cells. So tumor cells becomes dormant. Okay, and then eventually there would be escape. And what is escape? Escape will involve immunoediting. So when we say immunoediting, immunoediting has altered the phenotype of the cell. So it will alter the phenotype of the cell. Ibig sabihin, mag-iiba yung itsura ng cell. And once the phenotype of the cell is altered, it will result into reduced immunogenicity. What does it mean? It will mask tumor antigens. Diba? When you say mask, nakatago yung original face. And if once the antigen is masked, then it becomes resistant to immune defense. So this is now where we are defeated. This is now already a checkmate. So development of such changes is enhanced in the inflammatory microenvironment of the tumor and promotes tumor growth. So once nagkaroon ng resistant to immune defense, there would be tumor growth. Kapag nagkaroon ng tumor growth, it is uncontrolled already and can result into organ failure and eventually death of the patient. So immunoediting is the most important thing or the initial step that will happen during the escape. Okay, so there is what you call immunotherapy. Okay, so immunotherapy is also known as biological response modifier therapy. So it uses the ability of the immune system to destroy tumor cells. So we can have the so-called active immunotherapy. In active immunotherapy, it will stimulate patient's immune system to respond to immunoantigen. So we can give non-specific stimulation such as cholestoxin. So the reason why we call it cholestoxin, because cholestoxin was first developed by Dr. William Coley back in 1981. So medyo matagal na to. And it is consisted of a mixture of killed bacteria. Okay, so this is a non-specific stimulation. So if we give killed bacteria to our body, this will stimulate our immune system to become more active. Okay? BCG, I think you are all familiar with this one. BCG is Bacillus calmette-guerin, which came from Mycobacterium bovis, and we are using this as an active immunization against tuberculosis. Okay. Nowadays, we also have cancer vaccine. So it's a preventive preventive. We can prevent HPV, human papilloma virus, to prevent cervical cancer, or hepatitis B to prevent liver cancer, hepatitis B virus vaccine. So to prevent liver cancer, do you know that hepatitis B may also be considered as an oncogenic virus? That's the reason why you cannot go to internship without completely having the dosages required for hepatitis B. Okay. So cancer vaccines is preventive or therapeutic because there is what you call TSA specific therapy known as Provenge. What is it, Provenge? Provenge has already been approved by US FDA. Okay, so it is the vaccine for advanced prostate cancer. Okay, so advanced, so people with prostate cancer can still be cured by Provenge. It uses patient immune cells. So what's the compositions of Provenge? So Provenge utilizes patient immune cells. Okay, the patient immune cells is stimulated by Provenge. So the Provenge is actually consists of fusion protein. Okay, and then this fusion protein is made up of prostatic acid plus phosphatase antigen plus the cytokine coming from GM-CSF. If you're familiar in hematology, in hematopoiesis, the granulocyte monocyte colony stimulating factor. So that is the composition of Provenge. So what will be the action of Provenge? So the action of Provenge is that it will activate dendritic cells and T cells. So Provenge will activate dendritic cells and T cells. So these are examples of immunotherapy, okay, that we can use for treatment of cancer. But that's only for PSA. And then passive immunotherapy is also possible. So when you say passive immunotherapy, this is the administration of soluble antibodies or soluble components of the immune system. So, for example, cytokines to non-specifically boost the immune response and increase the white blood cell production. So we can give GM-CSF, interleukin-2 or alpha interferon, so that it will stimulate our body to produce more WBCs. So monoclonal antibodies that target specific immunoantigens are also possible. So for example, we can give patients monoclonal antibodies to cell surface antigen because this one will destroy tumor cells by opsonization. It will destroy tumor cells by opsonization, by complement activation, or by antibody-dependent cytotoxic activity, okay, cell cytotoxicity. Okay, so that is if we give patients antibodies to surface antigen. We can also give antibodies to surface receptor. Okay, antibodies to against cell surface receptors. If we give antibodies against cell surface receptors, this one will block signaling pathways. This will block signaling pathways for cell proliferation and survival, meaning to say the tumor cells will not anymore proliferate, and hopefully they will undergo apoptosis. Okay. Monoclonal antibodies to angiogenesis factors. What are angiogenesis factors? Angiogenesis factors will stimulate the formation of blood vessels, and we do not want this to happen because once blood vessels are stimulated, this will induce metastasis. Metastasis. And once metastasis is induced, it will cause the invasion and spread of cancer cell. Therefore, if we give monoclonal antibodies against angiogenesis factor, this will inhibit the formation of blood vessels. It will inhibit the formation of blood vessels. We can also give monoclonal antibodies to molecules that block the T cell activation. Okay, particularly the activation of CTLA4. Okay, because this will actually prevent inhibition of T cell responses that could destroy tumor. Okay, so if we allow T cell to freely destroy the tumor and do not anymore inhibit it, that would be beneficial for us. Okay, so sometimes we can also give monoclonal antibodies, antibody drug conjugates. Okay, uh, what do you mean by conjugate? Conjugate is composed of two things, no? So when you say conjugate, it is consists of two things. The first one is immunotoxins consisting of monoclonal antibody to a TSA to a TSA conjugated molecule. Okay, and this one is conjugated monoclonal antibody to a TSA conjugated molecule or conjugated potent toxic molecule. Okay, so again, what's the composition of antibody drug conjugate? Immunotoxin consisting of monoclonal antibody to a TSA conjugated to a potent toxic molecule. And then this particular toxic molecule will be delivered to the tumor cells. So antibody plus toxic molecules will be given to the tumor cells, and that will surely cause the destruction of the tumor cells. So these are all examples of passive immunotherapy. Okay. And then another one is the adoptive immunotherapy. Okay. Adoptive immunotherapy, I think we have already discussed this during prelims when we discussed about vaccine. It is the transfer of cells of the immune system. Now, in this particular context, we are talking about the TILs. TIL stands for tumor infiltrating lymphocytes. We're talking about tumor infiltrating lymphocytes. We can give TILs to melanoma patients. So TILs are obtained from a tumor that has been surgically removed from a patient and subcultured. So for example, this is now the tumor. You excise the tumor from the patient, and then you culture the tumor cells with interleukin-2. Okay. After you culture and subculture individual cells of tumor cells, okay, we test the individual cells to reactivity to tumor. And only those cells okay, that has shown anti-tumor activity should be given back to the patient because only these cells, for example, has a potential anti-tumor activity because of the specific tumor recognition, and then these cells should be given back to the patient, and then these cells will now eventually destroy the entire tumor. So this involves now genetically engineered T cells. And I think that's my last slide. Okay, that's my last slide for this particular lecture. Thank you very much for listening.